Hi, Marin from Indie Birth here with a video about fetal position in the uterus. So the best way to get this experience and knowledge really in your head and in your hands would be in real life. So maybe you can follow a midwife around, maybe you have a baby in your own uterus that you can feel and practice with. Textbooks are helpful in getting the basic information down. So here's my tattered copy of Anne Fry's Holistic Midwifery 1. There's a section, of course, on all of these terms I'm going to go over, but for many people, we learn better actually seeing it in as much dimension as possible. Best yet is maybe getting your own baby and pelvis to actually practice some of the terms that I'm going to go over today. I'm going to do my best with the baby and pelvis. This baby does not move as well as I would like, and sometimes it's a little bit awkward. I also have some flashcards to go through, but we'll do our best. So the very first flashcard here is fetal lie. How is the baby lying in the uterus? There are three possibilities here. The baby is longitudinal, oblique, or transverse. This is a simple classification. Before about 28 weeks, give or take, on certain bodies, it may be hard or impossible to really feel fetal parts. We'll talk about that later on. So when it's hard to feel what's what, so you're not sure, butt, head, but you are sure, or as sure as you can be, the direction that a baby is lying, that is lie. So longitudinal lie is simple. It's up and down. The baby is lying up and down. You may not know or care if the baby is head down, or maybe the baby is lying longitudinally this way, but in any case, there's the vertical axis of the baby against the mother's spine. So that's one lie possibility. The next would be oblique, which is the baby lying not quite up and down, but not quite side to side, kind of in between. So I don't know if you can see, it's not like this, it's more like that, kind of at an oblique angle into the pelvis. And then finally, a transverse lie is truly, a horizontal lie in the pelvis. And a baby that isn't quite ready to be born, so maybe at that 28-week mark or even before, it wouldn't be entirely uncommon or weird for a baby to lie this way, and you would probably feel it. You would just simply note that the baby was lying transverse. And in most cases, that literally rights itself before birth. So it's not something to worry about, of course, unless it's at term or in labor. That can be a problem, since a baby definitely cannot get out of the pelvis this way. So that's lie. There are those three possibilities with lie. Moving on. Okay, presentation. This only comes into play, like I said, once someone is past the 28-week mark. We honestly don't really care so much. Probably even around then, still babies flip and have plenty of room to do all kinds of things, and most will settle down into a nice cephalic or head down position before birth and in the weeks prior to birth. But if we're interested in classifying the presentation, it's what part of the baby is in the pelvis or leading from the pelvis. So there are three possibilities there: cephalic, which is a fancy name for head down, breech, which is bottom down, and there are some other possibilities there as well. And then, of course, transverse, that is a lie, but it's also a presentation, because in the transverse lie or presentation, a baby will present its shoulder. So let's visualize some of those, or those three. So pretty easy with cephalic. That's what most babies will do, especially at term, which is to be head down in the pelvis. We're not classifying it. I'm having trouble with my own pelvis here because everything is kind of like backwards in this video. It's just head down for the moment. We're not classifying it in any other detailed way. We're not classifying the angle of flexion in the baby's head or not, simply cephalic presentation. Breech, most people are familiar with. There's a couple varieties of breech, of course. Breech is just essentially bottoms first. So we can have a baby in a frank breech position like this. Babies can also kind of have legs down or feet down or a combination of those things. But the breech is what's presenting in the pelvis. And then transverse, similar to the lie, would be this way. And it would literally be a shoulder into the pelvis, which again is pretty much a no-go if someone is in labor. All right, next card. Attitude. It's a funny descriptive word for a fetus. So the attitude refers specifically to the head position in relationship to the baby's trunk and limbs. So again, most often, especially a term, we're going to have a baby that's in a cephalic or head down position. So when we talk about attitude, it's really the degree, and I don't need the pelvis necessarily at the moment, of flexion. See how the baby's head is tucked. It's really hard with this baby. Let's try it this way. See, baby's head is tucked. That is how most babies enter the pelvis and continue through the birth process before the heads are born. The heads are tucked quite nicely so that the optimum amount of space is only required. The smallest diameter of the head can be what leads the baby through the pelvis. So other degrees of flexion have different names, and that would be something to read in the book. So this is flexed. Deflexed would be the opposite. So a baby, that's kind of looking upwards or has its chin up or its brow presenting. There are many different varieties. Maybe that's not a good word since that's another vocabulary word. There are many different types of attitude, and it all refers to how the head is in relationship to the baby's trunk and limbs. Now, a baby can have its head in all kinds of positions, even if it's not in a cephalic presentation, obviously. Cephalic just means that is what's in the pelvis, that's what's leading, and normally as we get to term, we might care where we feel, the baby, the top part of the baby's head. So we can feel that in palpation, and I'll talk more about that, but we can check from the outside if we think the baby has a nice tucked, flexed head, or if we think that the widest part of the head might be presenting because the baby's deflexed. Obviously, or maybe not obviously, the same thing can be felt, although it's a little bit more difficult, at least for me, probably for everyone, just because breech babies are not as common. But when a baby is in a breech position, we still have the attitude of the fetal head. We still would love to know, if possible, that the baby has a nice flexed head if they're going to be born breech, rather than what we call a stargazer, where the head might be extended for a variety of reasons. So that's attitude in a nutshell. Okay, some of these words start to overlap, maybe get a little confusing, but you can read the book or rewatch the video and practice it on your own. So the denominator is a place agreed on by all the people that invented these things on the baby. So it's a point on the baby that is kind of our landmark point for whatever position the baby is in. So we use the landmark point to describe the position, which I'll get to next. So that's the denominator. And I like to think of that like, elementary school math, right? The lowest common denominator, basically the lowest part on the baby that we've all agreed to use as a way to describe other things. So I have occiput starred because And the occiput is the place on the head that presents in the cephalic presentations and is the denominator. That's the place we use on the baby to describe most head down positions. And of course, head down babies are the highest percentage of babies, especially at term. So that's why that one's starred. But there are other things that can act as the denominator depending on how the baby's situated in there. So the forehead is one, and that the formal name for that is called the frontum. And as I was describing attitude, if the baby is deflex, then you can potentially have a forehead presenting, and that would be the lowest denominator. That would be what you would use to describe that baby's position. The same with the chin. The sacrum in a breech position, right? So there's the baby's sacrum. And in a baby that's butt first, whether or not the legs are doing anything else, that's the position that we're going to use to describe that the baby is butt first. And then finally is the scapula, which of course, again, is that good old shoulder blade, which we really never want to see. But it is a possibility that a baby has its scapula as the denominator. Remember, we said that the baby might be laying, this way in the pelvis, kind of in that transverse lie. And that would be, can you see? Let's pretend that I have the pelvis up here. That would help, right? So the shoulder is really the only thing that's even vaguely in the pelvis in that position. And so we call that scapula the denominator. Okay, I hope you're with me so far. Here's where it starts to get maybe confusing, or maybe the light will be shed for many of you. It gets more fun. So let's talk about actual position. Confusing myself here. So technically, position refers to, is the baby on the left or the right of the mom's body? Or in the middle. Babies aren't always to one side. Variety is the next word. And stay with me here because I have to explain this in a way that I understand it too. The denominator, which we've already covered, which is that part that we've all agreed upon that might be in the pelvis that we're going to use to classify what position the baby is in, that part in relationship to the mom's pelvis. So remember, denominators most commonly is the occiput. And we, when we abbreviate that, which I'll get to, that's an O for occiput. If it's a sacrum, then it's S for sacrum. And so you can read all of these shorthand abbreviations in the book or search for it online. But just so you understand, as we're starting to call a position, because many of you who are students or maybe you're apprenticing, you kind of already have the full picture. Many of us do, right? So maybe everything I've said thus far has been new, but if you're feeling bellies at all, then you're used to naming a position, right? So a baby at term, and I'm going to get to that right now. But this is kind of like the backstory to all of this and knowing what the actual terms are that describe what we're talking about. Okay, so there are over 35 fetal positions. And again, we are classifying these based on 3 different categories that we kind of shoved together into an acronym. And we've already gone over these, but just so you can see how it fits together. The first is either an L or an R for being on the mother's left or right side. And as you can see in the OA, occasionally a baby is directly anterior or directly posterior or whatever it is. And so we don't use the L or R in those cases. The next part of this 3-letter acronym is the denominator. So if you look at the chart in Anne Fry's book or elsewhere with all of these different possibilities, most of them, or I should say the highest percentage, are the occiput, being the denominator, as we said. So most of these positions that you will feel if you're feeling babies at term will include the O as the middle letter. And then finally, we have the variety. Remember, that's the relationship of the denominator to the mother's pelvis. So categories are A for anterior. The baby's head, if it's an occiput, is in relationship to the anterior of her pelvis. P for posterior. T for the transverse. And that's a little tricky because the transverse isn't the same transverse when we're talking about a baby that is presenting its shoulder or lying vertically in the uterus. In the UK, I believe, they call it lateral. So they would call RST, for example, that would be right sacrum transverse, right sacrum lateral, I believe. I'm not in the UK, but that is my understanding. And that is a lot less confusing. We should take that up here. So anyway, these are what most people are familiar with, even if they're beginning students. Maybe they're writing this down in the chart or whatever, but this is how we're actually giving the most information about fetal position. Again, closer to term. This isn't something that you really care about or can necessarily assess in this much detail at the 28-week mark. It gets increasingly easier, but like I said, many people don't even care because babies can do all kinds of things. So we do start to care, we think, the month or so before birth. What is this baby doing? And, is there anything else we need to know? So I have a couple of these positions up here, and I'm going to attempt to demonstrate this with the baby and pelvis. But I'm going to have to put down the card, so bear with me. Okay, remember that it's in relationship to the mom. So this is the mom's left, and this is the mom's right. So even though I would be feeling, from the other side, so her left would feel like my right, that's not how we classify it. So this is her left, and we have a baby in a head down, a cephalic presentation. It's going to be really hard for me to flex the baby's head, but let's just assume that the occiput is presenting and this baby is nice and flexed. So if this is her left, this is the baby in left occiput transverse. And when a baby is in the transverse diameter, they are essentially looking at the other hip. And again, this is a description technically, in this case, of where the baby's occiput is, L-O-T. When we're doing palpation, which I'll touch on next, we are feeling the position of the baby's body, and the body's attached to the head, right? So that's how we are classifying, but technically, we are really talking about the position of the occiput, not the position of the body, but the body will almost always follow in that same position. Okay, so if we turn the baby towards the mother's anterior pelvis, then we have a baby in the L-O-A position, left, her left. Occiput is the denominator, and A for anterior because it's the denominator is in relationship to the anterior, which is the front of her pelvis. So hopefully that makes sense. Here we have a baby in the direct OA, so not left nor right, at least that's my intention here. The baby may look a little twisted, but it's meant to be directly anterior. And then of course on the right side we have the same thing in reverse, right? So ROA, ROT. Posterior positions get a lot of press nowadays of that being undesirable. It's certainly probably less common at term or before labor, but it's definitely something that people have gotten, in my opinion, way too worked up about. Babies can do all kinds of things. They can be in one position one moment and another a next. But posterior in general, posterior, again, remember that's the denominator in relationship to the posterior of the mother's pelvis. So you can have all kinds of posterior positions, whether they're a sacrum presenting or an occiput. Let's stick with the easy ones. So an occiput would be the head, the part of the head. So this is L-O, let's see, what do we think? L-O-P, right? Left occiput is in the posterior. different than having the back and the back of the head face the anterior. This is the opposite. So often we say with posterior positions, the way to remember them, oh my gosh, my hands are getting tired, is that the mom's spine and the baby's spine are closer to being lined up rather than opposite. So that would be LOP. This would be direct OP to the best of my ability here. And then of course on this side we have right occiput posterior. And of course, with a baby that remains in a posterior position, usually the mom reports lots of movement out front, right? All of these limbs are kind of dancing rather than a baby that's in the anterior and tucked, and the limbs are tucked in. So sorry, I'm not doing the greatest job with this pelvis. It's really disorienting to have a recording that's happening in the opposite direction. Let's see, what else was I going to cover with that? Oh, I guess we can just touch on some of the still normal but less common positions. So let's just take one of the breech positions. Remember that the denominator would be the sacrum for a breech position. And so let's have a baby on the mom's right, which is the most common breech position. And so this is her, poor baby. This is the right over here, right? And this is the baby's sacrum presenting the mom's right. And in this case, we have the sacrum in the transverse diameter, so RST. So hopefully that's clear. There's many more possibilities, again, some of which are really not as common, and I don't even know that I've felt a lot of the rarer ones just because most babies get in there in a pretty optimal position. And if they're not, it's probably more momentary and not something we're super focused on. But when we're listening for fetal heart tones, which I'll talk about next, we can also get a sense of position. So let's give my arm a break and finish up here with the good old, how do we know what position the baby's in? It's nice, right, when you can see the baby and the pelvis, and that's a great reason to get a doll and practice, because just getting the visual in your head is really helpful. So as you do that more and more, and you have the baby placed in the pelvis, in the position you are going for, then obviously you can also see where are the legs, where are the arms, as far as where fetal movement might occur, and also where you will hear optimum fetal heart tones with a fetoscope. So palpation is an art in and of itself, an art and science. And every midwife, in my experience, has a different way of palpating a belly. And so basically you're looking at placing your hands on a woman's uterus and feeling around for hard parts and for small parts, and feeling for what might be a head and what might be a butt based on other criteria. That takes some study and reading, so I would definitely check that out in Anne Fry's book, as well as other resources online. But your hands have to get used to feeling, so it can be really hard at first. I remember one of the first palpations that I was ever permitted to do when I was a student, and I felt her uterus so gingerly and timidly that I couldn't feel anything at all. So there is an art and a science to learning to palpate a uterus. Of course, every woman has a different body. Some women have a really easy to feel uterus and baby, some do not, and you have to press harder. So I like to think of it as being a detective. I think that a lot in midwifery in general, but just getting information, getting puzzle pieces that you put together. So if you want to practice fetal position, now you have all this information and you actually have to get your hands on some bellies to experiment without really naming it at first. Just get your hands on, and of course with her permission and all of that, start feeling around. Just what do you notice? And then you can start to put these words into practice and have something real life to compare it to, because it's all pretty abstract. You know, what does a head feel like? Well, we could talk about how a head feels different than a butt, but really it's best to experience that and have your hands figure that out. Oh, so back to palpation. Yes, that's all about palpation. You can look up Leopold's maneuvers, which is what we're all taught as midwives from textbooks. Obviously, something I learned as well long ago, but I don't think I even do it in order. So, there's a 4-step procedure, I think. I have my own method, as most of us do at this point. So it just really comes back to feeling what's in the uterus. What do you feel in the fundus, which is the topmost border of the uterus? What do you feel in the pelvis? What do you feel presenting? Where do you feel the small parts? So there's kind of a method that I believe it was a Dr. Leopold put together, and that's a great thing to just follow and learn right off the bat if you're interested. And then as you get better, you will kind of develop your own way of figuring out all of these things we've talked about. What's the denominator? What's presenting? What's the attitude? That will be information that comes with practice. Oh, the last thing that I was going to touch on, after you have the honor of palpating someone's belly, assuming again they have a baby that's fairly easy to feel, so maybe let's say 36 weeks, you have in your head or your hands what you think this baby is doing in there as far as what the position is, right? So let's say you palpate a good old, totally typical textbook LOT position, right? So everybody remembers what that means. And I'm probably not going to get this figured out. Oh, that's as good as I can do. Okay, so that's a pretty textbook position, LOT. On the mother's left side, occiput is the denominator in the transverse. So looking at the mom's hip. And so what are you going to feel? I'll just say this briefly. You're going to identify probably the bum up top connected to a back. You're going to feel the bulk of the baby along her left side. You're going to ask her maybe where she's feeling movement. That's going to line up with where you feel these little small parts over here, etc., etc. But let's move on to fetal heart tones just for a minute. You're listening with a fetoscope, I hope, which takes practice. A Doppler is A, not necessarily risk-free, but B, it's really hard to learn good palpation and the intricacies of listening for where you actually hear the baby's heartbeat. So if you don't know what I mean, get a fetoscope and start playing around with that. But a Doppler, I like to say, can pick up a heartbeat anywhere. So that's not exactly true. Maybe that's a bit of an exaggeration. But in other words, you will hear the heartbeat with a fetoscope, which is a stethoscope, where the heart actually is. It's fairly hard to pick up the heartbeat of a baby where the heartbeat isn't. Although as you get good with the fetoscope, you certainly can hear cord, for example, which beats at the same rate as the baby's heart. But what you're going for is looking to hear the point of maximum intensity. So even now, still, after a decade plus of listening to heart tones with a fetoscope, I'll always listen around. I'll say that to the mom too. So I'll find where I think the heartbeat is the most pronounced. So the loudest, the most clear, the easiest to count. That's probably the point of maximum intensity. And that's almost always over the baby's left shoulder. Right? Yes, our heart's on the left. But then, like I said, I'll listen around and I'll be able to hear it other places just because, but it won't be as loud. It won't be as clear. And so if you can identify the point of maximum intensity, which this baby, let's see here, this is the left shoulder. So, right here on the mom for an LOT baby, sometimes it's even closer to her hip than you might think, then that confirms the position that you have probably identified with your hands. It's not always 100%. It's not always super simple. There are times, even for experienced midwives, where, well, maybe we're not sure, honestly. We know the baby's in a longitudinal lie, right? But we're really not sure 100% of the time that there is a head presenting. We're not sure if it's a head or a butt. So maybe we'll listen for fetal heart tones, and that will give us a clue. It doesn't always, but listening for the point of maximum intensity with a fetoscope will help you potentially determine position. So there's probably some information in Anne Fry's book as far as where to listen, but I think I gave you a pretty good example. If a baby's in a posterior position, remember, like this, let's take a baby in the OP, whether it's left or right, whatever. This one's kind of in the direct OP. You're going to hear the fetal heart rate probably, in the center of her uterus. So not really off to one side or another. And again, that's just a clue. It doesn't mean for sure her baby is lying posterior, but we're not really lying in a posterior position, but some other things might give you a clue. She might report, like I said, lots of movement up front, or you might feel that the head feels pretty wide. It doesn't feel nice and flexed. It feels deflexed, because that's usually the attitude of a baby in a posterior position. And again, whether or not that actually matters is sort of a separate discussion. This is more of a just like puzzle piece. How is the baby? What is the baby doing in there? For our own skill and to be able to communicate that to the mother. Let's take again the stereotypical breech position. So that good old RSA, remember, right sacrum anterior. And let's see, this is the baby's left shoulder over here closest to me, which, is kind of tucked back here, but regardless, you probably are going to hear the fetal heart tones with a fetoscope rather high. So, it can be hard to know, get a bigger sense of what's happening here with this giant pelvis and no uterus around it, no person. But in general, let me back up, a baby that is in a cephalic presentation, especially towards term, if the baby is really nice and tucked in there, you're going to hear the heart tones fairly low on her uterus, so way below her belly button, sometimes almost near the pubic bone, or very low to one side or another. But a baby in a breech position, as you might imagine, is, sitting up. So their hearts are higher in the uterus, and you might hear the fetal heart tones with the fetoscope right at the belly button or even above. So again, that's not definitive. None of these things, without being able to peer in there, we don't have ultrasound eyes. We don't know 100%, I think, really ever. Certainly breech babies are missed. Certainly there are surprise breaches even in labor. But I think these words, these skills can help us do the best we can to classify and to describe to the mom what's going on, if she wants to know, or if we feel like we need to know, or again, just for practice, as we're communicating perhaps with other midwives. It can be really helpful to know these terms well and to have them solid, and to start to develop solid skills in your hands and in your mind and in your heart, because this is a vital part of midwifery. Our hands and learning to feel can really give us a lot of information. So I hope this tutorial has been helpful. I'd love to hear your feedback, and I hope this helps on your journey in learning what the baby's up to in there. Have a great day.